Welcome, everybody, to another edition of the Stanford Health Policy Forum. My name is Keith Humphreys. I'm a professor here in the medical school, which has sponsored this series for many years. And it meets a couple times a year to bring top thinkers and doers here to teach us about health policy, health promotion, health care. The advisory committee met last time, several of us have been taken by an article with a title I wish I'd thought of in New England Journal of Medicine, Your Money or Your Life, which is about the ruinous cost of cancer care. And this was for people who had insurance, by the way, specifically Medicare. And we all thought this is a very important issue, for us as we run, of course, a cancer center, but also for the nation. And that's why we made it the focus of this forum. And we have the perfect people to walk us through these issues, starting, of course, with Dr. Dusetzina, who wrote the article that we read and we're so impressed by. She is a health services researcher focusing on the intersection between health policy, epidemiology, and economics related to prescription drugs. She is a professor of health policy and the Ingram Professor of Cancer Research at Vanderbilt University Medical School. And her influence is very large. It includes co-authoring a National Academies of Science, Engineering, and Medicine report on making medicines affordable, and being selected to serve on MedPAC, which is the advisory committee for Medicare to determine what is reimbursed. We're also always happy to show off our own fabulous faculty, and we've got Dr. Alyce Adams here. She is the inaugural Stanford Medicine Innovation Professor and a professor of health policy, epidemiology, and population health, and also of pediatrics by courtesy. Dr. Adams' interdisciplinary research seeks to evaluate the impact of changes in drug coverage policy on access to essential medications, understand the drivers of ethnic and racial disparities in treatment adherence among insured populations, and test strategies for maximizing the benefits of treatment outcomes while minimizing harms through informed decision-making. Hosting, as usual, is Paul Costello. Paul ran communications at the medical school for many years, and we're very lucky that we get to keep him. He's kind enough to stay with us. He's an adjunct lecturer in the Department of Medicine and a Global Health Faculty Fellow in the Stanford Center for Innovation in Global Health. And so Paul will run the conversation for usually about 45 minutes or so, and then we'll open it up to your questions. So thanks very much for being here, and enjoy the show.
Thanks, Keith. We've been doing this for how many years, Keith?
I think almost 20.
20 years we've been doing this forum, so we're glad that you all could come out today and talk to us. Keith mentioned two things. One is about your money or your life. And so the first question I want to ask, is that the reality of people who are going through cancer treatment? And this is called also the cost of cancer. And there are a lot of costs of cancer, the emotional cost of cancer, the financial cost of cancer, and I think we'll touch on both of those. So the first question I want to pose to each of you, and I just want to say as a footnote that I asked both women if I could call them by their first name in the conversation. They agreed to that. What do you think most people don't understand about the dilemma facing older Americans seeking treatment for cancer? What do you think, if you were to talk to people in this room or to go out anywhere in America, take a poll, what wouldn't they get about the current dilemma and dynamics of what's going on? Why don't we start with you?
Yeah, so I think one of the things that people don't really realize is how your Medicare benefits don't really cover you for drugs that are offered on the pharmacy benefit, especially cancer drugs that are really expensive. So most of the time you think, oh, you're on Medicare, it's great coverage, you'll be fine. That is not true, and there's no way to shop your way out of having poor coverage for orally administered cancer drugs. So I think that would surprise most people that, when you're older, your coverage is just not good enough. To me, that is something that has been a glaring issue for a long time. I think the other thing is the inequity between the types of benefits that most people have. So if you need cancer treatments under a medical benefit on Medicare, most people have supplemental coverage that makes that very low cost to them, or maybe no cost, and there's an out-of-pocket limit on some plans. But again, the orally administered drugs don't have those same benefits. So it's really this difference in both you're really not covered the way you might think you would be, and that depending on the type of drug you need, you may have better or worse coverage.
Let me follow up just before I ask Alyce. When people go into treatment, Who tells them that? A physician doesn't sit down with them and say, by the way, I don't think you can pay for your treatment program. So how do they learn that? Is it suddenly they wake up and they find that they have these horrendous bills?
Yeah, usually you know when you get hit with this, they tell you how much it's going to be out of pocket to fill your drug. So when you think about filling a drug that is a pill, you usually think about going to the pharmacy. You have to pay before you get to take that bottle of pills home. With infused drugs, you get the treatment and then you get a bill later. So you might find out that your coverage wasn't as good as you thought or that you owe a lot, but you usually get the treatment first and bill later. Often what happens for people who need orally administered drugs is they try to fill them. They're told that their price literally is over $3,000 out of pocket for most of the commonly used drugs just for one bottle of pills. And that's when you realize what you're facing.
Alyce, what's your perspective on this?
Oh, yeah, I completely agree with all of that. And just to add to it, there are a couple of things that people don't understand. And that one is that physicians often don't know what someone's going to pay out of pocket, right? So they're writing the script thinking that this is the right thing for the patient, and the patient doesn't find out till later. And often patients don't go back to their doctor and tell them they can't afford it. Right? So there's this break in the chain of communication there. Another thing is that people hear often that pharmaceutical companies, don't they give those things out for free? Or aren't there community programs that are available? Yes, there are, but there are all sorts of caveats. So for example, sometimes these things only last for 30 days. And then you have to reapply, and if they decide that on the second time around that it's not, you don't qualify for whatever reason, you could be in the same situation again. The other is medical financial assistance, which is something that most, all really, non-for-profit hospitals have to have via the IRS in order to claim their nonprofit status. So with that, you can actually apply to those programs and hypothetically have those medications paid for some period of time. But there's all sorts of issues there. One is most people don't even know about it, despite efforts under Obamacare and other legislation to actually publicize these programs. Most people still don't know they exist. And often, so you still get the medical bill first. So from personal experience, I can speak to this as well as the patients we speak with. Often, no one tells you that this is available to you. You get the bill, you can't pay it. The bill collectors start calling. And often, by the time you figure out that there's something that you can use, how much stress and suffering have you gone through between bill collectors and everything else? Maybe you've even started paying the bill before you even realize this is available. So that's another issue. And physicians, again, don't necessarily know that's an option. It's much more known in the hospital setting where you have caseworkers and others who are focused on finances. And certainly in cancer centers, you often have patient advisors and people who are supposed to help you through that process. But it's still a very windy road, and not everyone's getting care in those places.
Do we know the amount of people, what the percentage of people who forego their medications because they can't pay? They're given a prescription, they can't pay for it, and so they just say, I can't move forward. Do we know what that percentage is?
So we've estimated this using data from 11 different academic medical centers. So this is, people who have gone out of their way to go to some of the best cancer centers in the country to get care. We looked at people who were newly prescribed orally administered drugs and who had Medicare benefits. We found that 30% of those people never filled the drugs that had been prescribed to them by their doctor.
30% is a whopping number.
It is enormous. I mean, and one of the things I think to Alyce's point about these well-resourced centers, this is your best case scenario. These are places that have financial counselors, navigators, they understand all of the systems in place. And, if you think about people going outside of these places, the percentage could be much higher. I'll say one example, we included Vanderbilt's clinics as part of this study, along with many other health systems. And in talking with a specialty pharmacist in our cancer center there, she said, we started our specialty pharmacy program because we knew this was happening for our patients. We knew that we were prescribing drugs, they were leaving, not filling them, and they would come back to get a checkup, and they would be like, I didn't start it. Like if they might not tell you, but they were saying we couldn't afford to start. So they've actually built most of those systems to try to fix the problem that we still see popping up 30% of the time.
Who's to blame for this mess? Is it pharmaceutical
Do you want to take
companies? Is it Congress? Is it inertia in general? Why can't we find, I just came back from 3 months in Europe where drugs are accessible and they're cheap. and everyone could get them. Why can't we do that in the United States? What's going on here?
So I'll say that one of the challenges around drug prices in the US is that we have all of these different purchasers. We also have never forced this question of having a price that aligns with value. So other countries that have similar economies to ours do these assessments of the cost effectiveness of a new product, and they'll say, you know, we need to have this price discounted to make it work for our population based on the benefits it provides, and we won't pay more than that, and if you can't get to an agreement, we're not going to offer it to anybody in the country. So they use their leverage as one purchaser to really get those negotiations done. And companies are willing to make those agreements most of the time. You know, there are examples where they don't, and those drugs are not available in the countries who have not been able to come to an agreement. But I think that recognizing that there is movement, like they can negotiate better prices. We could do that too if we had the political will to do so.
And we don't have the political will because of special interests?
Yes.
Yeah, special interests, and we have a culture in this country which is very much individualistic.
Yes.
Right, and so that also goes against the idea of collectively doing something for the greater good, sadly. And you can even see it, it's in the data, right? You can see it in terms of how much we actually pay for healthcare relative to other countries. And right around when pharmaceuticals became sort of the primary way in which we treat people, particularly for chronic disease, you saw this divergence between our costs, which kept going up, and costs in Europe, which were going up, but not nearly at the same rate because they had this policy arm that they could use to help to bring the costs down. So you can see it. The proof is in the pudding in terms of how much we're actually paying, and we're probably getting less.
Besides the passion that each of you brings to the area by your scholarly research, you also have families, and you have families who have struggled with health issues. And so I want to ask you, how has that informed you in the work that you do? I know, you know, it's your mother who has cancer. You have family members who have a multitude of health issues. What have you learned from that, from their circumstances, and how has that helped you understand the larger problem?
So, you know, for me personally, I started down this path of studying the way that Medicare Part D works for high-priced drugs a long time ago. And I remember my mom once saying, "Why don't you study cardiovascular disease? Because that's what everybody in the family dies from." And I was like, well, you know, it's like, I really think this is an important problem. Cancer drugs are like a good example of the types of drugs people can't afford, but there are many others that people can't afford under Medicare. It became much more personal to me. My mom was diagnosed with metastatic breast cancer in July of 2020. And I remember driving from Tennessee to North Carolina, and a colleague of mine who was on the oncology team was like, "I'll call you once we have some tumor-related information." And she called me while I was driving, and she said, you know, it's possible it's going to be this more common type of cancer, and we would recommend, you know, these two treatments, or it could be this other type, we'd recommend these things. And I remember thinking, oh no, if it's the common type, she's going to need an orally administered drug. They're going to recommend this drug that's going to cost her $15,000 out of pocket every year for the one drug. And she doesn't have the funds, and she would not want me to pay for her to have that treatment. And I remember just thinking, I don't know how it's going to turn out, but the fact that, you know, like, it's a toss-up whether or not you're financially secure or not while you're already dealing with this horrible event, and that you have to add this layer of financial insecurity on top of what is already a really terrible time for you and your family.
Absolutely, yeah, very similar. So for me, I got into this whole interest in policy to start with because I would visit my relatives in Oklahoma and Arkansas over the summers. They were all older adults. And literally, just every visit, another piece of them was missing, literally. So it would be a toe amputation, then a foot amputation, then a lower leg, et cetera. And so, or they'd go blind, or like so many different things were happening. They were losing their faculties and losing their functioning over time. And the saddest part about that is they all had health insurance. They were either veterans with military coverage and Medicare. Some of them also had Medicaid, and some of them also had Indian Health Service coverage. And we still saw these horrific outcomes. When I asked about it at the time, the idea was like, oh, but people would say things like, oh, well, that's just what happens to us when we get diabetes or heart disease. And I thought, how horrific is this? This is the best we can do, you know? And so that really stuck with me, and it's really driven me all along. Now I have, my mom's a cancer survivor, breast cancer, and my dad's actively undergoing cancer treatment. And just not 2 months ago, I had this experience where my dad calls me. He's like, I can't afford this medication, but I don't want you to pay for it. What am I going to do? I've run out on that 30 days for the pharmaceutical company benefit that I had. And so I had to go and call his, it was United Managed Care, talk to them, find out what he was actually covered for. And then I literally wrote out a script for my parents, gave them the script and said, this is what you need to ask in terms of what, and he was totally covered, but he had spent so many weeks fretting and worrying. He's 96 years old, right? And here he is worrying about this. And it just made me so angry. And then I thought, what if he didn't have a daughter who studies this stuff for a living? Like, how are you supposed to navigate all of this if you don't even have that? And so I thought that was shocking, and it's so frustrating, and it makes you feel very helpless. Like, here I am with a PhD in one of the greatest universities in the world, and I'm struggling to help him.
Yeah.
You said that they all had health insurance. So what was the issue and problem there if they all had health insurance? The VA is one of the best systems in the world, perhaps. Why was their care so poor?
One of the reasons the care is so poor is because we focus on the end result. We don't focus on prevention, right? We do not focus on prevention. We focus on what happens when you get in the hospital. So once you get in the hospital, often, some things are often covered and you have a little bit better coverage. But what we don't do very well is really treat people and prevent these bad outcomes from happening. And in particular, the ongoing day-to-day stuff, we just don't do very well. Like, we don't have a great way of reaching out to people, meeting them where they are, and helping them to navigate these really terrible and difficult chronic conditions. This is not an easy thing to do, right? Often you hear the doctors like, well, lose weight. Are you kidding me? Losing weight is not simple. It's never been simple. If it were simple, we would not have an obesity epidemic, right? But we don't have a good way of doing that, and our money right now does not go to primary care. It does not go to prevention, right? It goes to tertiary care and specialty care, and that's where people end up. And so I think part of it is a sort of value system where we're focusing on the wrong things.
The Inflation Reduction Act was passed by the Congress and signed by the President earlier this year. And it's supposed to be monumental in what it offers in incremental steps to manage prices. So where are we now with that? What's the beginning? How many cancer drugs are in the formulation for negotiation at this point? And in the long term, what is it going to mean? Is it going to be a real revolution in prescription care, healthcare in general?
Yeah, so I feel like I'm slightly biased in that I might be the Inflation Reduction Act's biggest fan. I think it's going to make a world of difference for people like the people I described in that article, the people who need access to these high-priced specialty drugs under Medicare. So the law basically will allow for drug price negotiation in the Medicare program for the first time. It's a huge change that there's any negotiation. They're negotiating for a small number of drugs, but it was illegal to do so before now. So this is a huge change in policy. In addition, they are completely revamping the Medicare Part D benefit. So that's the outpatient prescription drug benefit. So even starting next year, there will be a limit on how much people have to spend. So if you're filling one of those cancer drugs, instead of unlimited out-of-pocket spending, you'll spend about $3,200. And then in 2025, you spend only $2,000, and that's all of the spending that you have across all of your drugs.
So you get a cap on drugs, and then the rest of that is paid for by?
Yeah, so it will push more of the spending onto health plans. There are other things that are happening with the redesigned benefit that try to lower spending by the Medicare program or the taxpayers and increase the spending by plans when people are filling drugs. There's also spending by drug manufacturers, so they'll have to kick in some part of the drug cost and more once people hit the cap. So those changes also are a really dramatic improvement in the benefit. So we have to pay for that somehow. And the ways we pay for that are through the drug price negotiation. And there's also limits on drug price increases. So companies, if they raise their prices for their drugs faster than inflation, they have to pay those dollars back to Medicare. Those savings will go to pay for this benefits expansion.
Now, are pharmaceutical companies still fighting this? Are they still trying to end it? Are they still saying, one of their arguments has been, or one of their many arguments, what you're doing is cutting off innovation. You will not get new drugs if you proceed with this. What's the reality? What are the holes in their argument?
So the first 10 drugs that are going to be negotiated have already been identified, and those are basically selected based on the gross sales, so how much money you made in the Medicare program. They literally take that list and they sort it top to bottom, and they pick the first 10. So they're selecting drugs that are older. They have to be at least 9 years or 13 years old, depending on if they're a small molecule or a pill versus a biologic. And they're blockbusters. They're literally making the companies billions of dollars per year in most of these cases. And so, companies are pushing back. All 10 of the manufacturers of those drugs have sued the government to try to stop the negotiations. That's what they're supposed to do. They're for-profit companies. They'd like to keep making as much profit as possible, so we should expect that. But I think, how much do they have to lose? They've made a huge amount of money. That's why they're on the list. They will still have sales. So one of the things that I think people miss when they think about this negotiation process is you'll get a new price, but you also are now going to be offered under a redesigned Medicare benefit that is extremely generous. So you might actually make up from lower price, more sales volume, and everybody's better off under that scenario. Let me also say for the arguments around innovation, I think that there are real debates here about how much cutting prices for manufacturers affect innovation. I think that's one reason that I'm pleased that the initial attempt focuses on a smaller number of drugs, so we get that experience to really see what happens to the market, because we want companies to innovate. But we could do a much better job as a country of saying what type of innovation we want. We don't do that now, so we pay an extremely high price for all cancer drugs, the ones that are practically cures and the ones that do nothing but, they don't extend your life and they may just add side effects. So I think we could do a better job of showing the industry what type of innovation we want to value, let them handsomely be rewarded for those really innovative products, and stop overpaying for things that don't work.
You testified before the Senate on these issues. Do you find a bipartisan sort of coalition of concern in the Senate about the reality of how these situations are hitting Americans?
I think everybody agrees that they don't want patients on the hook for paying super high prices, but there's not as much agreement about the source of that solution. So I think especially along party lines, Republicans are much more vocal about concerns around innovation. And I do think it's fair to be concerned about that. But what you often hear framed in Congress and these debates are, we're going to lose cures. And I don't think that's a fair characterization of what is likely to happen when we start to pull back on spending. I think that companies will still have a lot of incentives to innovate and bring excellent drugs to market. And again, the more we can provide them with financial incentives to say, if you bring a great drug to market, you get a huge reward, I think we should be doing that. But I do think that politically, there are a lot of challenges. The pharmaceutical industry spends an enormous amount of money lobbying, and that includes to all members of Congress, basically everyone. So it is very difficult to change policy in a way that affects the price and the revenue for the pharmaceutical manufacturers. A lot easier to get everybody to agree that patients should pay less.
Alyce, you have said when it comes to quality improvement, a rising tide does not raise all boats. And I found that very curious. What do you mean by that?
What I mean by that is when we even see very high performing, what we call learning healthcare systems, integrated healthcare systems that in theory should be addressing all the way from prevention all the way through to tertiary care and doing it well according to the metrics that we look at for quality, even in those settings, we still see disparities in terms of outcomes, whether they be by race or income or rurality or other factors. And so what that means is even when people have equal access to more or less high quality care, everyone doesn't necessarily reap the full benefits of having that access. And I think there are lots of different reasons for that, but in particular in the studies that we've done, we found that part of it is these systems are really set up for patients who are super proactive. Right? And so the way that you can best take advantage of what these systems have to offer is you go online, you seek out all the different benefits that are available to you, you spend a whole lot of time trying to figure these things out. Well, who doesn't have a lot of time to do that? People who are working 2 and 3 jobs, taking care of kids, what have you, don't have a lot of time to do that. Often these websites are not in their primary language. So they might be in English, they may not have access that way. There's also sort of issues of unconscious bias and how comfortable you feel walking into a healthcare system. Do they treat you in a way that's respectful? Or you feel like you want to get care from these folks? The list goes on and on and on. And so there's sort of all of these different things that get in the way of people being able to access care. And some of the work that we've been doing is trying to work with health systems to say, okay, you can't just put something out there and say, if we build it, they will come. Instead, you really have to think hard about, well, on average, you may look like you're doing okay. It's important for you to look at those subgroups who are not doing well and to say what's a tailoring that we could do to reach out to those subgroups. I mentioned Medicare financial assistance earlier. Often the people that are at greatest risk for bad outcomes and underuse of clinically essential services aren't actually accessing medical financial assistance. So what if you tailor medical financial assistance, you tailor medication or copay reduction interventions to those individuals who need it most, right? And there are ways in which we are using machine learning and other strategies for being able to identify those people, but helping the healthcare system to say, we're not asking you to bear the full burden of all costs, right? But what we are asking for you to do is to think about equity anytime you do these interventions, in the sense that the very people that need it the most may have the hardest time getting it unless you deliberately reach out to them and tailor the interventions to benefit their needs.
Do you find that providers, clinicians, those who are in institutions really understand the problem, that they really take the problem to heart? No.
Well, I think that they care a lot. I think they're in the profession because they care. However, the number of times clinicians have said, well, the first time I started doing this work, I had clinicians coming up to me and saying, why are you even looking at this? We don't have disparities here. We have the highest performing, health plan, whatever. And so they just really, truly believe that disparities could not exist in their systems because they don't feel that way about people, so how could it possibly be? The other thing is they would tell me is, if my patient's having an issue, they'll just come talk to me. Patients don't like to talk to their doctors about their problems, especially, just depending on whether there's a language gap or some sort of other social context gap. And so there's sort of these assumptions, I think, that physicians make and clinicians make about patients and their behavior that are also often quite fundamentally wrong about what patients actually need. And so you mentioned before, like, we're the experts in financial toxicity. I think the patients who experience these things are the real experts, not us. Right? And so talking with them, understanding what they go through on a daily basis, that's the only way we're really going to understand how to address these these fundamental issues and barriers that they face.
When you look at the data, what are the major causes of the healthcare disparities among vulnerable populations? Can you enumerate them?
Yeah, you've probably heard a lot about social determinants of health, right? So it's this recognition that in the past when we talked about disparities, there was this effort to, if we only educate people, or if we only, sort of teach people what they need to do, then they'll have better outcomes. Well, it turns out that the outcomes that we see are a product of the system in which we exist, right? We've talked about the fragmented healthcare system as it exists, but even beyond the healthcare system, the society in which we live is not equal. We see that every day. You can see it here in the sort of the county where we sit, where the distance between the richest and the poorest is something like the highest in the world. in terms of that gap in equality. And so when you think about those things, where people live, the resources that they have, et cetera, those are the fundamental drivers of these disparities. That's why we see them everywhere throughout all health systems, whether they are high quality or not. And then when you pile on issues related to healthcare systems, I mentioned unconscious bias is one, but that's just one. We talked about health insurance access. So there's a number of other things getting in the way of people getting the care that they need. So if you only focus on people's behavior, you're not going to get there. You've really got to consider the entire system and all of the sort of flavors of factors and practices that contribute to the perpetuation of these disparities over time.
Redlining is a practice in real estate that prevents people of color from moving into certain neighborhoods. And they are actually, I grew up in the south side of Chicago, and I know there were actually areas that were redlined. How has redlining affected healthcare for minorities?
I think others have done much more research on redlining than I have personally, but I know there have been some recent studies showing a direct relationship between redlining and health outcomes, and that's likely a number of different factors. To give you an example, we had done a study not too long ago at Kaiser Permanente looking at risk of COVID. This was sort of during the COVID pandemic. We all stopped what we were doing and said, let's figure this out. And so we wanted to understand what was driving disparities that we were seeing in terms of hospitalization, but also in terms of mortality due to COVID. And by far, what was driving that was these differences by race that we were seeing was where you lived. Right? Your ability to get out from under other people, whether or not you had the ability to skip work, right, or to work from home. But I had the privilege of just taking my laptop home. Many people don't have that privilege. That is a privilege, right? And so we have those things compounded, including gentrification within these communities where they were sort of on top of each other, pollution, all of these other things affecting them. But in addition, just sort of being cramped in these cramped spaces, that was a big driver of whether or not you were even exposed.
Stacie, when we spoke a couple weeks ago, you said something that I found very interesting, that the lack of value for many cancer drugs, and that patients often equate high prices with good drugs, but that's not the case. What are the ramifications of that, and how do patients see pricing and treatment outcomes?
Yeah, one of the things that I think is super frustrating is that we all think about if it's higher prices, maybe better, because that's usually the way things we buy work. Like you pay more, you get a better product, right?
Brands.
And in fact, that's not true. So you would imagine that if you were a Medicare beneficiary trying to fill one of these prescriptions, that if they wanted $3,000 from you for your first prescription, you would expect that drug to actually have a clinical benefit for you. And that is actually not the case for many of the drugs that are priced in that way. So one of the things that I think is very frustrating about this particular system is, that person is facing this high cost, and they will assume that that drug would work for them. And walking away from it because they can't afford it then feels like you are giving up, right? So like you are sacrificing your health, when in reality, you might not be making any difference at all in your health. But you now have the mental burden, and your family has the burden of thinking that you're giving up on a treatment that could have improved your life or increased the quality or length of your life. So I find that to be completely outrageous. I think the prices should reflect the value, because that could at least signal this might not be as valuable for you. We should make it really clear to patients when they're taking a drug that is maybe not going to benefit them. And I think that part of that is on the clinicians. Even as a person who studies cancer drugs and now has family member with cancer, I found it very difficult to navigate the system and decide what is worth pursuing and what is not, as someone who studies this, as my job. And so I really do think that it, emphasizes to me the importance of, your care team really thinking about, is this a high value action for my patient? What happens if they have severe financial consequences? What if they have to sell their home or, move in with family members or sacrifice eating? Because that's the reality for people in many cases. And just thinking about that before making that prescribing decision, because you're putting people in a real jam, because, not pursuing a treatment your doctor has suggested for you feels really hard in this situation.
Is that the term, you've used the term when we've spoken, financial toxicity, and I know drug toxicity. What is financial? I assume it's what you've just been talking about, the catastrophic impact.
Yeah, exactly. So researchers many years back had coined this term financial toxicity in the space of cancer to talk about, the financial effects of having to pay for all of this treatment and how burdensome they can be on patients, and really trying to recognize that, when you're thinking about making a prescribing decision, it's not just about, the actual toxicities of the drug, like how you'll feel, will you have nausea, these sorts of things, but also like how much of a financial effect is it going to have on you. And, I do think fairly the tools for your clinician to even know what that effect would be are really not as good as they should be, given where we should be with technology. So often, I say that clinicians should have a better sense of like this and make these decisions, but sometimes they don't know. For one patient, it could be that that drug is absolutely no cost to them because of the type of health insurance they have, and for others, it could be thousands of dollars. But I think that's where, coming back to this equity component, it's like that decision should be based on the drug's effects on the person, not necessarily what that person has to pay out of pocket. Because we know that we have disparities. If you have lower income, you probably have worse health insurance. So if you keep making decisions about who gets treatment and who doesn't based on what the health insurance pays, you are driving more inequities in the system.
And just to add on to that, I think it's that with the assumptions that you make about whether or not someone's willing to pay. We see a lot of this in diabetes and insulin and other areas where clinicians are making decisions for patients, thinking that they understand what the patient's needs. And often those can flow along racial and ethnic lines, which are really more about unconscious bias and less about actual knowledge of the copay. So these things sort of kind of compound each other over time.
Yeah.
You worked in the pharmaceutical industry. I don't believe you ever did. What is the perspective when it comes to priorities and about, is the word altruism ever uttered in the halls are they thinking about drug pricing and the impact upon patients and the impact upon treatment? Is that any sort of equation, or is it like the bottom line of trade? Their companies are publicly traded.
Yeah, I'll say that, frankly, I think it depends on your job in the industry, like what exactly you do. So I had the privilege of working with multiple pharmaceutical companies and working on the research side of the business. And I do fully believe that people who are doing research in the pharmaceutical industry are doing phenomenal work, and they're totally invested in improving patients' lives. The higher up the chain you get, the people in the C-suite, they're making some financial decisions. They have boards actually that, that make some of these decisions about pricing that, I'll give an example. One that I found to be really interesting was a smaller biotech company that had developed a treatment for a rare disease. And I remember reading this account where the scientist involved in developing the treatment had really wanted and intended for this drug to be priced responsibly because they knew how important that was to the community that they were trying to serve. And I remember reading an article, and they said that they were shocked when the price was announced. It was decided by their board, and they didn't get their input. They couldn't give input and actually change the price. And they felt kind of hurt by the fact that now the price was so high that the people who needed the drug might not have access to it. So I think, as all things, it's complicated, but I do think it's important to remember that, the pharmaceutical industry is very diverse. A lot of what we see as, small biotech companies come from academic labs. They come from people who are really passionate about solving a health problem. But, at the end of the day, many of them are publicly traded companies. They have shareholders, and their responsibility is to earn as much money as possible. So they have these dual missions, improve health, but also make money.
Why are we stuck? Why can't we move forward in many different ways, especially with the inequitable problems of healthcare in this country? And at least if you could change any one thing, is there any one thing to change? Is there any one thing that would cause perhaps the domino effect?
gosh, that's a hard question. I feel like we work in fits and starts. I'm not sure. So I don't think it's that nothing ever changes. It's just that we are a country of incremental change as far as health policy is concerned. And sometimes those incremental changes or even reform, like we saw with Obamacare or the ACA, you can actually see significant impacts on patient or person's health. The challenge is all the clawing back that we do, right? We tend to go forward and then we move back. We tend to go. I liken it to we have these it's almost like we have this sort of very short-term memory as a country, and we'll be going along and we sort of learn something about, if you take care of people's health and they work harder and you get better productivity and everyone's better, and then we kind of forget that. And then we sort of go along forgetting it for a while and sort of clawing back on health because it's so costly, and then we sort of have this reawakening. We say, oh, wait, what do you mean there are disparities? People aren't healthy? Right? We do this periodically over the course of history. And so I don't think it's that we never move. I think things have a hard time sticking. But once they do stick, like Medicaid and Medicare, for example, was one such reform that we hadn't seen before, have had some staying power. Are they perfect? Absolutely not. Do they need work? Absolutely. But the more that, but once they're in, it's sort of harder to take away those benefits. So I think that's one strategy. And I'm just a big believer in ensuring that the people most affected by the decisions that get made at the policy level are actually involved in the decision making. Right? The more I talk with patients and clinicians and community providers and community organizations about what's going on in their communities, the more I realize how little I know about what that experience is like. And that's critically important. One, it's important to tell stories in policymaking. People need to hear stories and they need to understand that impact. But also we miss out on innovations that we might have thought about before just by talking with them about different ways of doing things. So that's one of the big things that I think we need to do is start bringing in deliberately for bidirectional learning between policymakers and the patients who are actually being affected and their families.
I want to close this portion, and then we'll take questions from everyone in the audience who wants to pose a question. Are you optimistic? I mean, it would seem that with the Inflation Reduction Act, Stacie, you're optimistic about the changes that are on the horizon. Do you both look at the future with optimism?
So I will say that healthcare policy you can think about as a bunch of patches to a broken system. This is an excellent patch for a really broken part of one of our systems. Is that, am I optimistic? Yes, for Medicare beneficiaries over the next few years, yes, I'm optimistic. Do I think things are going to get worse when it comes to spending and the financial viability of the system as a whole? Probably. I think we're going to end up breaking it so badly that we have to do something new.
Because of baby boomers getting into...
Yeah, we're looking at doubling Medicare spending by 2030. Doubling. And we're already high. We're already worried about, how do we pay for Medicare? So I think we have many, reckonings coming. But I think as far as, patching up a huge hole in a policy, that said, I think that we have many things on the horizon that are going to really test our healthcare system and this really fragmented nature of it. So examples are gene and cell therapies. We're talking about treatments that are $2 or $3 million per person right now for rare disease. And how do we think about paying for that? What if it hits your Medicaid budget? I guess good luck with the potholes in the road. I mean, you're going to have to figure out a way to fill those funds and pay for these things. Same thing with looking at things like the new obesity-targeted medications. We're talking about 40% of people in the country who have obesity. So thinking about even a small percentage of those individuals taking these drugs, even if they're heavily discounted, it is a massive expenditure on the budget. And because we're so fragmented, it's does your plan when you're a younger person want to pay for you to have obesity treatments that all the benefits accrue to Medicare? Probably not. So I think we're going to, it's a nice patch for now, but I think we're going to have to really reckon with, is this multi-part system really serving us well? Because I don't think it is.
And the costs.
Yeah, absolutely.
Alyce, what are your thoughts?
I would agree with all of that. I think on the positive side as well, I think the more we think outside of the health system and health policy box into broader social policies, the better, especially in terms of addressing those fundamental causes of disparities in the healthcare that we do see, or health outcomes that we do see. So to give an example, these experiments that are being done sometimes at the county level or at the city level, guaranteed income, various sort of out-of-the-box thinking about how do we shore up people more financially such that while this other stuff is getting fixed, they don't go bankrupt trying to pay for their cancer care, right? And so David Grusky and David Rykoff have a great U-grant opportunity right now on persistent poverty areas, looking at the impact of things like county level or even city level sort of earned guaranteed income experiments, as well as our state has a very generous earned income tax credit program to see what's the impact of those things on people's access to cancer care and their cancer outcomes, right? And I think the more that we understand about that, those sort of experiments then become proof of concept for what we could do on a broader level. So that just sort of gives me hope as well.
Thank you both.
Thank you.
Thank you.
And we'll take questions now. We have some microphones, and there's a question here, a question here.
Hi, it was just fantastic. So I have a question a little bit more about the Inflation Reduction Act. So only one of the 10 drugs that was on the list is a cancer drug because it sort of ranks by total spending, so it's not actually looking at price. So especially for cancer that are such targeted drugs that treat small patient populations, how do you think that sort of opening the door to negotiation maybe down the road actually might address price and not just total spending? Thank you.
Yeah, that's a great question. I think I was a little bit surprised there was only one cancer drug on the list because I think those who had been trying to guess which drugs would make the top, they thought there would be a couple, 2 or 3 on the top list. I think there will be 2 dynamics moving forward. So one is, this is the first year of selecting drugs. And because you're picking any drug that's at least 9 years old for the small molecules for these, Part D covered drugs, I think we've got a little bit of a backlog of chronic disease medications that'll move through in the first years of negotiation, and we might end up with a bigger mix of like high price, smaller number of people taking them, negotiated in future years. So I do think that cancer drugs are going to be a big part of it. The other thing is that the drugs are selected based on gross sales, so it ignores rebates and discounts. And we know that for 9 out of 10 of the drugs on the list, they get huge rebates. So the actual amount that is the ranked spending that got them on the top of the list is probably not nearly as high as what was actually spent on those drugs. One thing that could happen is that companies recognizing that they might be targeted, even though they're not making that much money, is they may push down their list prices to stay off the top of the list. So you might end up, and that's good for us no matter what. So a lot of the ways the law was written, I think, have these kind of intentional, things to try to put more pressure on that price. So the price that is on that list is more similar to what was actually paid by the program. If that happens, more cancer drugs are going to go up to the top of the list because they don't get those discounts. So I think that'll be great. I also think there's going to be more savings with those drugs. So when I look at the top 10 lists that got pulled, I think I would expect pretty minimal savings for those commonly used drugs because they get big rebates today. I would instead expect a huge amount of discounts. Even if you took 25% off the price of that cancer drug, you'd save a lot of money in Medicare.
Go ahead.
Hello, I'm from Norway, so this is a very interesting discussion. I want to pick up on one of the things. So we have, of course, the countrywide negotiations of prices. But listening to you, I'm also thinking that part of that is getting the price down. But part of it is also having an open discussion about the value. Because coming from sort of on a national level, because it doesn't mean that this is perfect, because patients are not happy when drugs are not offered. That it is a problem. It's not paradise over there. But I think it's maybe the fact that you actually have this open discussion about cost effectiveness and that is maybe not as valuable as you might think. is an important part of that negotiation, not only the price.
Yeah, absolutely. So most of the other countries who negotiate, they explicitly do cost effectiveness analysis. So they look very squarely at what are the benefits of this treatment relative to whatever the standard of care is, and what should the additional costs be given those benefits. And I think that's exactly right. The drugs that tend to be left off of formularies in other countries tend to be ones where the price is just too high given the clinical benefit. So I think there is a lot of debate. You know, in the US, we culturally want access to everything, regardless of the level of benefits, apparently. But I think that there are criticisms because when you're in the situation of you have a rare condition, a drug is coming out, you want access to it, you want to try. And I think that does create tension for people when they can't make those deals happen. Also, I'd say I went to Norway last year, and it is basically paradise. So,
So just to follow up on that question, I'm wondering about, you know, for a while now, we've had sort of this tension around funding of studies that actually do comparative effectiveness. And I don't know do you know what the latest is on that? How are we doing in terms of opening up the possibilities of doing more of that work?
So I think it's definitely come a long way. I remember like my first class in pharmacoeconomics in grad school where they said, oh, we don't really measure value or take it into account. I was like, what? Why? Like, that seems like a terrible idea. But, you know, we've come a long way since then, so it's becoming much more common that people are talking about cost effectiveness of drugs. We have the Institute for Clinical and Economic Review, ICER, that's a, you know, not-for-profit group. They are sort of the public group that does this, not formally for, you know, the government or anything like that, but they provide this information about how much discounting would be needed for a new drug to reach cost effectiveness. You know, even with the Inflation Reduction Act, there is they're going to establish a fair price. Mm-hmm. It's going to be based on a lot of information they collect from the manufacturers, including information on clinical benefit. Though the biggest contention is not using QALYs. So quality adjusted life years are, there's legislation that is written, and including in the Inflation Reduction Act, you're not supposed to use measures that, as they say, would discriminate against one group or another. I think you could have a very robust debate about whether that measure is actually discriminatory, but there are efforts to move away from specific measures, but I think there is more appetite for it and more recognition that that's something we need to be considering.
So I think you mentioned that the Inflation Reduction Act might be kind of an important first step. And I'm wondering what might be practical future steps. And it seems like sometimes the debate is whether it should be more transparency, especially upfront for providers and for patients, or if it should be more moving towards a formalized cost-effectiveness analysis on the payer, and which of those areas you think might be more important.
So when I think about like the first step piece of this, a lot of it's around issues on the price negotiation and how we've approached that. So the Inflation Reduction Act focuses on older drugs. It also limits price increases for existing drugs. It notably does nothing about new drugs. And so I think there is a lot of concern that new drugs will just come onto the market with substantially higher prices than before. So I think there is an important kind of elephant in the room of, okay, well, we targeted older drugs to try to be careful about the effects on innovation, but at the same time, we don't know how that's going to kind of blow up in our face when it comes to Medicare spending. And I think cancer drugs in particular are going to be the poster child for what's going to happen because they have mandatory coverage under Medicare. So there's no way to negotiate those prices and walk away. You know, I personally would like to see more intentionality around cost effectiveness analysis and getting pricing that aligns more with value. And especially as you think about these really rare disease treatments, the gene and cell therapies, you know, these are absolutely phenomenal. Like, you have someone with an incredibly rare disease who could be cured. We should handsomely reward that activity. But we can't do that and then pay whatever companies want for not really that effective drugs. So if we want to pay a premium for the drugs that really work, we have to stop overpaying for the drugs that don't. And I think if we really move our policies in that direction, that's where innovation will go. So we'll have, more focus on these really big wins, which would be great for people's health. But those would be my wish list items. I think it's going to take a little while. I think we have to break the spending part more before we start to solve for that.
And I'm excited too about some of the work that's being done here on campus too around ethics and this decision making, right? So CEA is a tool, and it's a really effective tool in helping us to make decisions, but it can't be the only thing that we think about.
Yeah.
And so layering a layer of ethics and ethical frameworks for making decisions, I think would be incredibly helpful, right? Because everything you're talking about ultimately comes down to ethics. Like ultimately, when push comes to shove, are we going to be okay with this decision? And how do we come about that sort of rationalization?
Yeah.
And I'd like to see more of that integrated more deliberately into the work that's being done.
Yeah, I'll absolutely agree. And I think one good example of this is sometimes when people talk about incorporating more cost-effectiveness analysis, they say, we couldn't afford to pay as much as a cost-effectiveness analysis would suggest is needed for some products. Like they're just that good relative to the standard of care. And then you think about drugs that would affect a very large number of people. So if we had a really effective Alzheimer's treatment, the obesity drugs, it looks like they have really huge improvements in like clinical outcomes that are important to us. So I think one of the ethical considerations is not just like let them get as much money as a cost effectiveness analysis says they should, but like your total budget impact. Because at the end of the day, the health insurance company is not absorbing those increased spending. They are passing it on to all of us. So as taxpayers and as people with health insurance, we get to pay for that. So we have to also think rationally about, where is the common sense level of reward that really emphasizes like we want great treatments, but also recognizes we are taking money away from people, and we might actually be making it so that many people can't afford to have even basic health insurance coverage.
In the same vein as the previous question, with the pricing clock from the IRA starting at drug launch, how do you foresee pharma companies changing their launch strategy, specifically around their initial indications and what implications there might be for patients?
Yeah, I think this is a really interesting space, and people are starting to do research in this area. So one of the concerns is that if you're a company who hasn't yet entered the market, and cancer is a really good example for this, because often we have, like a particular tumor type that they test in first, and then they move to others. So one concern is that a company might strategically delay launching their product until they have proof that it works in the larger group of patients. I think that there are some real concerns and things we need to monitor. And again, this is why I think starting with this smaller number of products is smart, because we can then look intentionally at what's happening in the industry and how are they responding as far as development. Again, drugs are only picked if they're at the very top of Medicare spending. So they are truly blockbusters. So I think, it's hard to consider a company has something that is truly going to be transformative for a patient and then just saying, no, we'll wait. Like, now we'll just finish this other trial. They could be making money now. So, I think there will be some consideration of that, and companies are indicating that. But companies also have it in their best interest to say the sky is falling right now. So there were, for example, really public declarations about killing off a product that was under development. Drugs get killed off in the pipeline all the time. Like, it always happens. They don't look that promising, they stop development. So I think that we have to be careful not to overreact to things that are coming out about like drug development, and just be really cautious about over-interpreting industry actions at the moment.
We also have to keep in mind that it's already changing anyway.
Yeah.
Right? Precision medicine is already changing the
Yeah.
drug development process, right? So all of these things are happening simultaneously. So it's probably not going to be one thing,
Yeah.
but sort of the combination of the two.
Agree.
Thank you both again, and thank you for joining us today.